Exercise Medicine Canada on campus at U of T presents Dr. Jonathon Fowles from Acadia University.
It's happy to be here today. I come to you straight from Oshawa, where I just gave a workshop this afternoon for a group of diabetes educators and talking about physical activity and exercise. And that work I will be sharing with you today, because that was kind of the framework for what developed the Exercises Medicine Canada initiative. So Mackenzie, when you talked to me, you saw me last year, I think at CSEP in Newfoundland, and I kind of talked about the Lawson initiative with diabetes. So I thought I'd do the full circle today, kind of talk about that and see how it brings back into the CDA. So there's my disclosures. I have received research funding support from TheraBand and Steps Count, and they now sponsor the Exercises Medicine program. So what if there is one prescription that could prevent and treat dozens of diseases such as diabetes, hypertension, and obesity? Would you want your doctors to prescribe it to their patients? Of course you would. And that is kind of the essence of what we're trying to promote with Exercises Medicine. That physical activity is a potent therapeutic agent. If we look at this slide, and this is just a snippet of kind of the dose-response effects that physical activity can provide across a number of chronic diseases. The green numbers there, which is the first numbers, are if you get the 150 minutes of moderate to vigorous physical activity per week, you can realize those first numbers there. 31% reduction in risk of premature death. If you do more than that, either accumulating some vigorous physical activity or exercise, or exceed the guidelines, you can realize that second number. So you can see a very, very potent effect. And there are some very recent studies just published in JAMA showing this exact dose response, that 30 minutes a day, 5 days a week, 31% reduction in risk of premature death, which is the hardest major outcome when you talk about evidence-based medicine. And that was done on 650,000 people followed up over 14 years. So very powerful database. As well as the vigorous exercise. If you do that as part of that 150 minutes, a further 10 to 13% reduction in risk of death. And if you get more than 3 times guidelines, up to 50% and even 60% reduction in that outline. That one physical activity dose or exercise dose relates to all those different chronic conditions. So when we look at the amount of Canadians achieving guidelines, if you ask Canadians, are you achieving 150 minutes? About half of Canadians will report that they are. However, when we use objective criteria, such as using pedometers or accelerometers, it's a little bit of a different story. This is the data from 2011 from our CHMS data from 2007-2009, showing that about 1 in 7 or 8 Canadians. Now we're up to almost 20% there in that number since 2007. So we've gone up quite a bit in the last little while, which is due to the big initiatives that CSEP has done and various other things. This afternoon, I was getting these black boxes on my computer as well, so I'm a little curious as to what's happening this afternoon. But anyway, the key thing though is that as Canadians, we're now sedentary, approximately 10 hours a day as adults. And it's about 9.5 hours as youth, which is the complete opposite to where we were as little as 100 to 200 years ago. Whereas stationary farmers, we were active, 8 to 10 hours a day, working the land, etc. So in the span of, a few hundred years, we've completely reversed our physiological profile. And that's kind of where we are now. In the past 50 years, since the 60s, they've documented that through work, leisure time, home energy expenditure, and transportation, that our physical activity levels have dropped between 350 and 500 calories per day since the 60s. So that's huge. Now, up to about the 80s, dietary intake also was falling. But then in the mid-80s, we know that there was the big explosion of, fast food and mass production, mass marketing of food. And also we kind of hit a low point with the social context of humans eating 3 meals a day. There's only so little food we can eat. But what's happened is this kind of spreading of this, calories in, calories out. And that's where our obesity epidemic is really coming from. And that now, today, as North Americans, we gain on average a half to a kilogram per year every year, just living in our society. And that means that the average person, by the time they reach retirement age, is 25 to 50 pounds overweight. This is just average, just from being in our society. And so in order to combat that, you have to, that's the normal behavior. So in order to be healthy in today's society, you have to behave abnormally, to swim upstream against this current that's pushing you in this direction. So much so, this is again the Canadian Health Measures Survey results that based on comparison to the health measures of the 1980s, where we tested 20,000 Canadians and we did 5,500 Canadians in 2007-2009, you can see that the average 12-year-old girl in this example gained almost 11 pounds. They got taller, their waist circumference went up, their grip strength went down, their sit and reach score went down, their aerobic fitness went down. And the thing was, this wasn't unique to 12-year-old girls. It was basically both boys and girls, and every demographic of a decade from age 9 up to age 70. Basically everybody was suffering from these low fitness scores. So Canadians today are taller, heavier, rounder, weaker, less flexible, and less aerobically fit than we were in the 1980s. And we even tested at Acadia our incoming first-year kin students, thinking, wow, kin students. I think you guys might have even done this testing. There's some Acadia grads here. And found the exact same results. Aerobic scores were down by 15%, strength scores, because we had data from the 80s when we used to do fitness testing to get into kin, or phys ed at the time. And strength scores were down 25%, waist circumference was up by 3 to 4 centimeters, body weights were up by almost the exact same thing. So it's every demographic of our society is in this boat. And so for the first time in history, our children's lifespan could be 2 to 5 years less than the generation before it. This will be the first time that a generation will not outlive its previous generation because of declining physical activity and declining fitness levels. Now the key thing is that this inactivity epidemic is even more concerning than the obesity epidemic, because the reduction in fitness is really what's facilitating chronic disease. You know, basically the imbalance in energy is the essence of physiology dis-ease. That's what disease is all about. And the number one thing is calories in, calories out, or energy imbalance. And because we've economized in everything that we do now, in the sake of innovation, like this, I'm saving, I don't know how many calories not walking back and forth to my computer just by using this wireless device, that fitness levels have been dropping. And so when we talk about in healthcare, some of the big risks in healthcare, and we talk about what's called community attributable risk, which is the magnitude of the effect multiplied by the percentage of the population that has that risk factor. Low cardiorespiratory fitness now is the biggest public health problem of the 21st century. It's bigger than smoking, hypertension, high cholesterol. Like smoking is the equivalent health risk of having low cardiorespiratory fitness. However, only about 20% of the population smokes, whereas 80% of the population is at risk of having low fitness levels now. And so that's why it's a big player in healthcare, or it should be. Now, the real concern, though, is that this is the healthcare tsunami that we're facing. Is that we know that by each decade, each demographic, diabetes rates are going up. And by the year 2030, 1 in 3 Canadians will have pre-diabetes or diabetes. Now, part of the reason why things go up with age is because after the age of 30, our muscle mass peaks, and it goes like this, and after about age 50, it starts to exponentially decline. Well, when you don't use your muscle mass, 80 to 90% of blood glucose is deposited in muscle. So if you don't use your muscles, where does it go? In the blood. And that's what precipitates kind of these diabetes rates. Now, this one is not the scary slide, though. Believe it or not, this one is. Which is the decade, year upon year, doubling of diabetes rates over the last 30 years. Each decade, a doubling of diabetes rates. Over the last 30 years, threefold times. Okay, so it doesn't matter what age you pick here. If it's 25 to 29, it goes from a crude prevalence rate of 0.6 to 1.1. So it's doubling even in 25-year-olds. It's doubling in 80-year-olds. And then now you put the population demographics of our baby boomers hitting there. There's our healthcare tsunami. So that by the year 2035, if you take all the money to fund this increase in healthcare, there's no money for anything else. You do that, and you pay for education, and the other 58 departments of the federal government disappear. Okay, so that's the tsunami that we're facing. Total healthcare costs of physical inactivity related to the primary, so direct and indirect healthcare costs alone, $7 billion a year. And when we factor in excess weight and physical inactivity on burden of chronic disease, so that means reduced productivity at work, absenteeism, workers' compensation costs, $30 billion a year in Canada. The US statistics are like $400 billion a year due to this problem. Now the thing is though that there's an opportunity. The projected cost savings of increasing physical activity by 1% per year, meaning that if we go from 20% of Canadians reaching 150 minutes to 21%, could save $2 billion a year. Or if you're at 100 minutes, getting to 110 minutes, that same 10% relative or 1% absolute could save $2 billion a year. So there's a window here of opportunity to change the course of action. The problem, however, is in primary care right now, the number of Canadians that receive recommendations on physical activity and healthy diet, for example, is relatively low. To increase physical activity, if you don't have diabetes, about 10% of Canadians get a specific recommendation around physical activity. If you have diabetes, it goes all the way up to 15%, which still isn't a lot. Okay, there's dietary recommendations, 10%. If you don't have diabetes, it goes up to 30% if you do. But still, there's a big room for growth there. So that's where this is a great quote: the significant problems we face cannot be solved at the same level of thinking we were at when we created them. So within society, we've created a society where physical activity is the abnormal behavior and healthy eating is the abnormal behavior. So we have to reverse that, which is anytime we have the opportunity to engage our bodies in physical activity, it contributes to our health. And anytime we choose to take an escalator or an elevator or whatever, we're robbing our bodies of that health. So we have to keep that in mind. The other thing is that within healthcare, it's called healthcare, but it's really illness care. That when we cross a certain threshold and you get diagnosed with a condition, we can throw a whole bunch of healthcare resources at that, billions of dollars worth, but we're still not up to 2% of healthcare spending on prevention. Well, we know an ounce of prevention is worth a pound of cure in this situation, and we need to change that. We need to change that healthcare is really about promoting health, and physical activity is a big, big part of that. So where do we go from here? At your age, good health is pretty much a thing of the past. Find an illness you enjoy. My advice is find an illness you enjoy. That's not really, it's funny, but it's not, in that we do have to do something dramatically different. In the 70s, there was this thing called the Lalonde Report that talked about preventive healthcare and physical activity and lifestyle and all these things. And basically, I've seen reports that have said that nothing's changed since the 70s. Well, now we're getting, just like climate change, we're getting to this point where we're getting so close to the edge that if we don't do something now, that we're really going to be in trouble. Okay, so the climate change of the world is very similar to what we're facing as humans with regards to this physical inactivity problem. So do we continue to do the same things and expect different results? What's that the definition of? Insanity. Right? We can't do the same things and expect something different to magically happen. We do have to change our perspective. So that's kind of where I came from with my research focus, was how can we change the healthcare system and the paradigms around physical activity and evaluate it. Because medicine is evidence-based. Unless you can prove something has an effect or a result, that it doesn't really matter what you say, you have to prove it. And so that's where we went with this. And I've been funded by the Lawson Foundation. I love them because they basically funded my research for the last 6 years. But the thing with the Lawson Foundation, they're a philanthropic organization, and they're not like CIHR and NSERC and all these other ones that are all research. The Lawson Foundation is about change. Like, they were very interested in what can we change about practice, about policy, and a little bit of research, which is really where I wanted to go. So, like I said, by the numbers there, the diabetes problems are major. But if somebody does 150 minutes per week of physical activity, with or without the resistance training, we can expect reductions for somebody with prediabetes, anywhere between 50 and 70% reduction in the incidence of diabetes if they meet these physical activity targets. The problem is when we first started this, in 2008, our surveys of diabetes patients, if they did the aerobic and the resistance exercise, the combination was the guidelines, less than 3% of people with diabetes were achieving that target. So that meant that within diabetes care, we weren't doing a very good job. So what could we do differently? Well, in diabetes care, it's believed that the patients have a lower efficacy or confidence in their abilities to perform physical activity. So they go to the diabetes educator. The model in Canada is that there's typically diabetes centers that are staffed by a nurse and a dietitian to help counsel and educate this person about managing their diabetes. And they have, a moderate confidence in their diabetes educator's ability to help them in this regard. So they go to their diabetes educator, who have little training. If you're a nurse or a dietitian, you probably haven't had any training in exercise prescription, unless you came from a kinesiology background, which is somewhat more the norm now, but it wasn't 10 years ago. And you have low confidence in your abilities to actually do this, as well as a low confidence in clients to actually follow through on that recommendation if you were to give it. So that creates kind of this vicious cycle. So that means you're probably less likely to focus on, to discuss this with your clients, and you're less likely to focus on physical activity or communicate with confidence about it. If you don't know what you're talking about, you're probably not even going to bring it up, because then you might get questions back where nobody as a healthcare provider wants to look like they don't know what they're doing, right? So you probably won't talk about it. And our data basically showed that less than 1/3 of diabetes educators were actually talking about physical activity in most of their appointments. Okay, so that's not good. So that, you can see, would probably feed back into maybe diabetes patients not having confidence to do it. Well, if they don't talk about it, I don't really believe what they're saying anyway, well then I probably won't do it. So you can see how that can work. And actually, when we observed diabetes visits, this is kind of was the paradigm. So right there, the diabetes background. So this was the average 30-minute first appointment with a diabetes patient. They did 2 minutes on diabetes background, about 6 minutes on diet, about 4 minutes on medication, self-monitoring of blood glucose was the next 3 minutes, then foot and eye care, then we talked about blood pressure, then we did behavior modification, and if it was talked about, it was usually the 8th to the 10th topic covered in that 30 minutes, and if it was talked about, on average, 2 minutes on physical activity. So you can understand why there's probably not a big uptake of physical activity for many diabetes patients. So that was something that we wanted to address. So with a colleague of mine, Dr. Chris Shields, we wrote the Diabetes Physical Activity and Exercise Toolkit. It was a best practice initiative from the Diabetes Care Program of Nova Scotia. It basically had a decision tree of how you could individualize a physical activity recommendation. There were brochures that went with each kind of prescription, all the way from reducing sedentary behavior to increasing physical activity to maybe beginning some resistance exercise to doing, or resistance activities to doing some actual exercise. And we implemented it in practice. We trained diabetes educators, and because we had the support of the Diabetes Care Program of Nova Scotia, they said, you shall do this. So we trained 125 out of the 135 diabetes educators in Nova Scotia on using this manual on counseling in practice. We used PEI in New Brunswick as our control group, so they were our standard care, which they didn't get the toolkit, and then we compared the intervention. So lo and behold, when we did the evaluation of this, we looked at the confidence of the diabetes educators on counseling about physical activity. And it went up by about 20%. So it went from approximately 45 to 48% up to 68 to 70%. Now, most of the information says if you want to be confident in talking about something with somebody, you need to be at least at a 7 out of 10 or a 70% confidence level. So we got them up to that level. It also increased their other efficacy, meaning that they even had more confidence in their patients to be able to follow through, because we explained some of the challenges that patients would have in this regard. So they went, oh, okay, so we need to talk a little differently in this regard. Instead of just telling people what to do and having them do it, we need to help them and guide them and do some motivational counseling. When we sampled the patients or studied the patients, they increased their resistance activities because we introduced this, low-level resistance band program, and increased moderate to vigorous physical activity for clients that were inactive at baseline. They went from, on average, 20 minutes a week of MVPA to 140 minutes a week of MVPA for the ones who had toolkit counseling. That's a pretty big change. But the ones that we were active at baseline, or somewhat active, didn't necessarily change that much. So what we identified was that there's a need for further counseling around exercise. As well as the diabetes educator said, we need a little bit more help. This is actually way harder than what I thought it was going to be. We need some exercise specialists here, some certified exercise physiologists and kinesiologists to help us out with this. Maybe deliver some classes, etc. So we offer these services to a bunch of locations, different diabetes centers around Nova Scotia. And they had counseling appointments, they could do one-on-one, they could do exercise instruction, they could do exercise classes. So what we found, so this was the second study from, this is now 2010 to 2012. And what we found is that we also wanted to see, because one of the criticisms is that, well, people with diabetes don't want to be active anyway, so why should I talk about it? So I said, well, let's just see. Offer them, a palette of things that they can partake in and see who comes. If you build it, well, they come. Well, about 50% of them got brochures, about 40% got one-on-one counseling from an exercise professional, almost half of the ones that we sampled attended an exercise class, and many of them got instruction on resistance exercise. On our pre to post sample of 100 patients, the resistance and aerobic exercise went up by almost a day per week, and the number of patients that reached that 150-minute threshold went up by 10%. Now remember, that's significant because if that happened across the board, we'd save billions of dollars in Canada. Now, one of the things that we also wanted to do was to do a subsample. What about, so that was the whole sample, that included people who didn't even do anything at all. So what if we just looked at the ones who went to the exercise classes alone? Well, you can see from this data that their physical activity levels went up quite dramatically, so 30 minutes a week. The percentage that meets the MVPA goes up by 12%. They go up in resistance exercise classes and aerobic exercise by at least a day per week by providing those services free of charge through the diabetes center. Now, what if they saw a kinesiologist? Would this be different than if they saw the nurse or the dietitian or just a personal trainer? And this actually, I did not plan these results at all, but it was very interesting to look at. It showed that the ones who actually saw a kinesiologist and got one-on-one counseling actually had clinical outcomes. They reduced their A1C significantly, which is in medicine, you're looking at clinical outcomes, not just did they get more active, did it actually have a change in their physiology, etc. You can see that their moderate physical activity went up by 40 minutes, or actually, 60 minutes, and the number that met that MVPA goes up quite a bit. And the other thing is their confidence actually stayed high, whereas in all the other groups, their confidence for exercise started to decline over time. So this was a big thing. And they maintained that efficacy or that confidence to be able to exercise by meeting with one of you guys. Now we also wanted to look at, what about because we disseminated this thing province-wide, we wanted to see, was there a province-wide evaluation instead of just the diabetes centers that we looked at. And in Nova Scotia, they have what's called the diabetes registry, meaning that every diabetes visit has to be recorded in this registry. So we said, if we've had an effect, then theoretically the number of patients that are reporting physical activity should go up, and the amount of physical activity should go up. And that's what happened. We pulled randomly 6,500 charts or files off the registry. So in 2007 to 2009, it went up a little bit. And then by the end of our implementation of the second phase in 2011, that went up by a relative increase of 20%, as well as an absolute increase of 20% of the number of patients having exercise recorded in their charts. So you see that if the confidence of the diabetes educators went up 20%, that translated to an awareness that there's 20% more charts now actually reporting it, and of those charts, 20% increase in the physical activity that they reported. So it all translated and it all worked, meaning that we're having population-wide effects. So that's where we come to 2012, and now that we've disseminated it through the Atlantic region, people are starting to call us, and I'm getting calls every single day. Do you have this toolkit thing? Can we get training? Can we do this? And so we thought that the best place for this resource was with the Canadian Diabetes Association. So we went back to the Lawson Foundation and said, how would you like to fund a national dissemination of this resource? And they said, sure, great. So that's what we did. We re-templated it as a CDA resource. We had a prescription pad that went with it, and then there was a number of materials that went out that summer explaining the resource and talking about physical activity. It was their #1 priority for the CDA that year, was to promote physical activity and to get it on the map. So there's our nice new brochures now, all re-templated with the CDA. So we signed it over to the CDA in 2012. And then we did workshops across the country. We trained over 1,200 diabetes care professionals in using this resource. So again, a big, huge implementation. We evaluated it, and the ones who went to the workshops showed that the workshops were very valuable to practice, that they engaged with practical information that they could use. It increased their confidence, and again, we did this 3 times now. Once in Nova Scotia, 20% increase in confidence. Then we did it in New Brunswick and PEI with another 200 diabetes educators, 20% increase in confidence. We did it nationally, sampled another 400 diabetes educators, a 20% increase in confidence. So we're kind of getting used to this thing kind of works in that way. But the key thing is it also increases the diabetes educators' confidence in their client's ability to do it, which is a big thing as well. When we asked them, are you going to change your practice? You know, most of them say yes. And then when we evaluated them 6 months or a year later and said, you said you were going to change your practice. Did you change your practice? 85% of diabetes educators did change their practice in the way that they said they would when they used the resource, such as talking about physical activity more, making it a priority, recommending, resources for physical activity in that regard. Most often they used the resource with inactive clients that are ready or planning for physical activity, and that was really what we wanted. That, there's a lot of clients that are aware of physical activity but don't know what to do. So this brochure, the Introductory Resistance Program, was actually the most popular one, because many people with diabetes can't actually go for a walk. That's always the recommendation, just go for a walk. Well, about 35% of them can't go for a walk because of their weight, they have foot problems, they have hip problems, orthopedic issues, they just can't last more than 5 minutes. So we did this resistance band training program. We developed a video for it that you can go on YouTube and go diabetes resistance exercise, and there's me kind of walking through this resistance program with people, and that became really, really popular. And many of the diabetes educators and diabetes centers in Nova Scotia now have this as standard practice. You have like a counting carbs seminar, you have a managing your salt, what's hypertension, resistance band class, and a walking class now at your diabetes center. And that's just standard practice now. And when we first started, it was 1/3 of diabetes educators in 2008, 1/3 were talking about physical activity in most appointments. And this one is the follow-up now of a national sample of 130 showing that there's 40% plus 25, so there's 65, almost 2/3 now of diabetes educators are now talking about physical activity in most of their appointments. So again, that's a huge paradigm shift. Normally it takes 17 years to get a 50% change in practice in any kind of clinical care. It takes 17 years. And so that was 6 years to get a 100% change in how that shifted. So that was a pretty big effect. So that's where we came down to where I'm going with exercise as medicine, and some of the learnings from this. One is that if you want things to change, you have to take the bull by the horns. Like, you can't just wait for other people to do the job for you. That if you want people to refer to you as an exercise physiologist, well, you better get out there and start talking to people. If you want things to change, well, then you need to change them. Okay, so the other thing was, it was relatively unique that this happened in Nova Scotia, and that's because we have the Diabetes Care Program of Nova Scotia, which is unique across the country. There's no other province that has a management program that unites all the diabetes centers together to do the same things. I come to Ontario and every single healthcare district or PCN or family care network is doing something completely different than the other ones, and they don't talk to each other, which I find weird. But in Nova Scotia, it was like, okay, let's get 130 diabetes educators in a room. Well, actually, that's what we did, introduction, but we did 15 workshops, so smaller. But we trained everybody and got them moving in the same direction, and that's what allowed kind of the thing to take over. We had the funding of the Lawson Foundation, which was amazing. Then we got the CDA on board, and FINIB is the First Nations Inuit Health Branch. I've now done, I think, 5 or 6 workshops for them nationally. And then we get partners involved, like Remington Medical and Steps Count and all these other things to support the workshops. The key thing, though, was that medicine is evidence-based. That unless you can show those outcomes, you're just talking, right? You have to show, if you're going to change things, you have to show data, cost-effectiveness data, outcome data. Just like you would if you were trying to justify use of a drug. You have to show a clinical outcome, you have to show, is it cost effective, and you have to show, can I implement it? And the thing with supply and demand is you have to kind of create a little bit of demand in order to get supply. Now, when I first started training diabetes educators, like nurses and dietitians, to do physical activity counseling, all of my kinesiology colleagues said, "What are you doing? You're giving away the keys to the castle." And I said, no, you just wait. They'll want us. They will. And they did. I remember after doing this for 2 years, and then I gave a talk at the New Brunswick Diabetes Education Annual Symposium, and I said, and what I'm really wanting to do here is make sure that you guys value the qualified exercise professionals to offer services and support you in this. And I got a standing ovation. I wasn't expecting that. But it just kind of showed that whole paradigm shift that they're like, yeah, we need you guys to help us out here because this is way harder than we thought. Okay, so there is that need now to understand what it is that we offer and what it is that we do. There's that funny black box again. So what does that mean for us? It means that we're still, as exercise professionals, kinesiologists, etc., we're still a little bit on the outside of healthcare looking in. We're getting windows in. There's now, in Ontario, kinesiology is a regulated profession. There's many kinesiologists that are part of family healthcare teams. It's in Alberta. There's kinesiologists as part of primary care networks. It's happening in BC and Quebec, etc. So it's happening now. Still in diabetes care, most diabetes centers are nurse and dietitian. Some of them now are hiring kinesiologists. So it's happening, where they're including and valuing our services. So it's shaping the context of care that in diabetes, the first things that the CDA says is to manage diet and physical activity and medications. But then they have the nurse, the dietitian, but no kinesiologist there. So that's what we're trying to shape the context of care, that we can provide a very valuable service within healthcare. There's that black box again. And that's where we came to with exercise as medicine. So Actually, I can't remember when this was, but it was on the way back, maybe from, this was around 2014 actually now. And so we just had our first meeting with Exercise as Medicine. It's an international initiative started in the US in 2007. And CSEP kind of took it over in 2012, and then developed a task force, and then formed an advisory council to disseminate Exercise as Medicine in 2014. Well, I was coming back from the meeting and I went, I wonder if the Lawson Foundation would be interested in supporting a national workshop campaign, because there's no better way to treat diabetes than to prevent it from occurring in the first place. So I called them up and said, how would you guys like to do it? And they said, sure. And literally 2 weeks later, they gave us a check to do this, basically because of the work that we've done to build this up. So like I said, it's now, Exercise as Medicine is now in 35 countries worldwide. And our advisory council in Canada is a multidisciplinary advisory council. So CSEP is the chair, but there's the Canadian Academy of Sport Medicine, Family Physicians of Canada, the Kinesiology Alliance, Nurses Association, Physiotherapy, Chiropractic, and everybody's there. And the key thing here is because we need as many oars in the water as we can if we're going to turn this ship around. Because there's 31 million Canadians that aren't active enough to get health benefits. So we need everybody pulling in the same direction. So there's our objectives, and Matt kind of talked about this, to increase the number of healthcare professionals that are talking about physical activity, prescribing exercise, to encourage the appropriate use of qualified exercise professionals in this regard, with the overall goal to increase the number of Canadians meeting guidelines. So why should physicians counsel on physical activity? Well, because they're a preferred source of health information. One of the things that when we did all the work with diabetes educators is that we figured out that the untapped market was really the physicians. And that, most people see their physician 3 times a year in Canada, and as you get older, it goes up to 5 or 6 times a year. So, there's a lot of contact there. And people have the number one source of health information is still identified, not Google, it's actually your doctor. Google comes in, close second now it seems, I don't know, but it's really still the most valued health information still comes from your doctor. And so, if they're not talking about physical activity as part of their health, then we have a problem. They get to know their patients well, they have relevant, common ground, and the evidence is so strong here that it's a primary risk factor. And some would argue that, physicians and all healthcare professionals, because the evidence is so strong, that we have a legal, moral obligation to actually talk about it. That if we're not talking about it within healthcare, it'd just be like if somebody had really high cholesterol levels, and you left that appointment and didn't get a statin drug, well, somebody would go, hey, there's a problem there. Well, if everybody leaves those appointments and doesn't get kind of recommendation to become more active, then, maybe that's a problem. And it's important for all ages, as well as primary, secondary, and tertiary prevention. There's lots of good evidence in this regard. Here's an example of one of the slides that I put up in my Exercise as Medicine talks with physicians. And this was a meta-analysis. This was actually a meta-epidemiological study, which took 16 different meta-analyses, so 305 randomized controlled trials involving over 300,000 participants, and compared head-to-head, is exercise, what does it compare to medications in the treatment of stroke, the secondary treatment of coronary heart disease, and diabetes, and heart failure. And as you can see, exercise was more effective for the treatment of stroke, was as effective as the secondary treatment of coronary heart disease. So, as effective as things like statin therapies, and calcium channel blockers, and beta blockers, and all these other things that are standard prescribed. 75% of people over the age of 55 are on a statin. So only 10% of them are getting a prescription for exercise. But the evidence says that it's as effective, and the cost effectiveness evidence shows that it's 5 times more cost effective than statin therapy for primary, secondary prevention of coronary heart disease. It wasn't as effective as diuretics in heart failure, but again, there was the hard outcome with this was mortality, so things like quality of life, of improvements in self-efficacy, improvements in strength, and all those other things weren't evaluated in this study that we know obviously has benefits as well. Here's an example, and just one, and I have literally 100 slides like this that are comparing kind of exercise to a typical therapy. So this is in hypertensive adults. There's our common kind of medical intervention, so a single ACE inhibitor. This is through systematic review and Cochrane reviews, 11 millimeter reduction in blood pressure. You do combination therapy, 15 millimeter. Those are pretty good changes. Antihypertensive, beta blockers, 8 and 10. Well, you can do some other things there, like the DASH diet, and we know that within hypertensive care, to see a dietitian, etc. Well, here's aerobic exercise down here. Cochrane database review, 8 millimeter reduction in blood pressure. And here's the hand grip exercise one. This one comes out of the McMaster. This is holding, 30% contraction for 2 minutes on, 2 minutes off, 2 minutes on at 30%. Switch to the other hand, do that 3 times a week. Average reduction in blood pressure is 10 millimeters of mercury in 2 months. That's hardly anything at all. It's a baroreceptor resetting kind of mechanism, and it's modest. You don't get huge changes in central blood pressure, but because you're resetting the baroreceptors, it has this change. Now that transfers all over to resistance training, etc. But there's some pretty major therapies. This one is pretty cost effective. If you get one of those little exercise balls, that costs about $3. There you go, 10 millimeter reduction. I can guarantee that these ones would cost a little bit more than that. Usually about $150 a month. Now, having said that, when we sample, confidence and things, so we're doing the same kind of evaluations with physicians now, and they report that same low confidence. That's the same confidence levels that we had when we first started sampling diabetes educators, nurses, and dietitians. So they're not that confident in talking about physical activity. Say there's a lack of education in medical school. I do a lot of talks with Dr. Paul O, who's the director of the Toronto Rehab Institute. We've done about 6 workshops together. And he says, I went through med school and I didn't get a single lecture on exercise. I didn't get any information whatsoever. But now that's what he talks about the most. He says, I'm a trained pharmacologist, and this stuff works better than just about any drug we can prescribe. So when he says that, I just sit back and go, okay. But it carries a lot of weight. Now this is something that's very interesting, is that many doctors will say patients are not interested in physical activity, or that they would prefer medications are the easy way out. A simple, just give me a drug. But really when you talk to patients, it's not like that. Patients would actually prefer not to have meds if they had an option to do their physical activity, if they knew what they were doing, and they had somebody to help them. They would choose that option. Actually, when we sampled 2,500 patients in Nova Scotia, we said, what's the number one way that you can increase your physical health? 65% of them said increase physical activity. The next closest one was change my diet, and that was 13%. 5% said take medication. Okay, so there's an awareness out there. 0% was drink less alcohol, which I thought was really fun. It was Nova Scotia. So. The key message there being that there is an awareness that physical activity is good, but maybe they don't know what to do. They don't know how long to do it, they don't know at what intensity, and so therefore they need some help. And our evidence shows that 4 out of 5 Canadians need our help in this regard. So how can we best deliver? So there's our actual data from the samples. So about 25% of physicians, and this is a national sample across 5 provinces, 25% of physicians assess physical activity on a regular basis. About 45% advise about physical activity. Now when you sample the patients, it's about half that. So 45% of physicians will say that they talked about it. About 16% of patients will say that they heard that. Okay, so sometimes there's communication, sometimes there's a little bit of over-reporting. The key thing is that more than 90% never actually prescribe exercise as part of a healthcare visit. Meaning, what are you going to do for how long at what intensity, something like that. Something actionable. Just a recommendation to be active, or to do, make sure you're active. That's how we've kind of categorized physical activity within healthcare. But we know that that does not work. It works no better than on January 1st, somebody saying, I'm going to eat better this year. We know that that's not specific, it's not actionable, and therefore you go back to the same behavior by January 2nd. So we need some specifics. We do know that physician counseling is effective because people have a high regard for their physicians, that in cluster RCTs it increases physical activity level, that the number needed to treat, and this is a big thing in healthcare, the number needed to treat. So many statins are anywhere between, say, 35 and 75 people in order to save one cardiac event. The number needed to treat to get one person to above 150 minutes is 12. So if you talk to 12 people, one of them, by that recommendation, will get up to 150 minutes with all those benefits. A similar kind of comparison, remember that if you increase physical activity, it's the equivalent of basically quitting smoking. It'd be the equivalent health benefit. To get one person to stop smoking, the number needed to treat is 50 to 120. Okay, so for 10 times less clinical effort, you could get the same health outcome. Okay, so that's another kind of comparison. We know that physicians can help improve weight loss, reduce blood pressure, reduce A1C when it's prescribed within practice. The first kind of example of this was called the green prescription. And this was from New Zealand, where I don't know why they called it the green prescription, I honestly don't. But there it is, right there, the green prescription. Maybe it was a green prescription pad, I'm not quite sure. But the physician issued the prescription, and then if the person wanted support, they were forwarded to a support person, a personnel support person, or I can't remember what the P part is, but anyway, support person. There's usually a nurse practitioner, a dietitian, or a kinesiologist, an exercise professional, that would call them up on the phone or meet at a community center and provide some extra support. So this was shown to be effective in getting relatively inactive people more active. And it was shown to be cost effective, meaning that the cost per quality, which is quality of life year, adjusted life year. So again, if I compare to statins, it's about $10,500 per quality if we use a statin. For physical activity, brief recommendations by a physician is about $500 per quality. Exercise referral and community support runs anywhere between $500 and $2,500 per quality. Usually in healthcare, anything below $50,000 is cost effective and we should do it. So we're talking 10 times less than the threshold. And in many studies it's shown to be cost saving in the first year. And the ones that are cost savings, you should jump on that right away. And so that's why I'm surprised when healthcare hasn't jumped on it right away. But anyway. So maybe the situation could be this. Lift 2 of these and you won't have to call me in the morning. That's actually a great ad from the Wellness Institute in Winnipeg. That's their ad. They have a medical fitness center facility. There's 5 of them in Canada and 2 of them are in Winnipeg. They're building another one because they're so popular and so effective there because they've done a really good job at showing their effectiveness and their cost effectiveness and their outcomes. So why else should physicians learn more about physical activity and exercise? Well, A, because hardly any of them got any of it in med school. And just about everywhere you go, it says, talk to your doctor to learn which heart rate zones are right for you. Well, if I surveyed, I would say 9 out of 10 doctors don't know what the different heart rate zones are. Like what's the fat burning zone? What's the cardio zone? What's the peak zone? Most physicians do not know. But when they come to our workshops, we explain it to them in simple terms. This is our moderate intensity. This is our cardio, is the aerobic zone from 60 to 80% of heart rate reserve or VO2. The peak zone is vigorous, above anaerobic threshold, above 80%. So you don't want to go there if somebody's never exercised before. You want to build them up through the moderate zone, etc. So we explain all that stuff in our workshops. So what's being done nationally in this regard? In British Columbia, physicians are writing scripts, and the BC government has put in a couple $1 million into this idea of incentivizing or incenting behaviors to support physical activity and healthy behaviors. And they're just kind of rolling it out now. They haven't, just kind of, Mark Mitchell is back there. He's one of the experts in Canada in this regard, and he's been consulting with a number of programs, and BC is one of them. Alberta, they have a program called prescriptiontogetactive.com, and this is a comprehensive program. There it is. This is the ad from the CBC in Leduc, Alberta. Doctors writing prescriptions to get patients active. What was that? That was 2013 was when that one was. But they have a website. Find a facility. Who are the primary care networks that are participating in this program? They have 3,000 physicians writing prescriptions in partnership with 80 community centers. And they go through a screening program so that they know that they have appropriate emergency procedures. They have qualified exercise professionals there. And as part of the PCN relationship, if you get a script, you can go there and get a free consult. You get a 1-hour consult with an exercise professional and a 2-week membership. Some of them give a 2-week membership, some of them give a 1-month membership to try it out. Now we know that not everybody wants to go to a gym to increase their physical activity, but it's an option that most people would rather just do it somewhere else, especially if you're overweight or if you have diabetes. Many people are afraid to go to a gym. But it's interesting because those medical fitness facilities in Winnipeg, all shapes and sizes, all diseases, young, old, big, small, everybody's there, and that's because they service everybody. And nobody looks out of place. It's not like going to, a high-end fitness center where everybody looks buff and those people with diabetes do not want to go there because they look different. Places where it becomes welcoming then can be more welcoming. In Ontario, about 15% of family health care networks have kinesiologists, but only about 5% offer exercise services on a regular basis. So although in Ontario, kinesiology is a regulated profession, we still have some room for growth here. And there's an opportunity to provide more services and cost effectiveness in this area. Does anybody hear about this one? In Quebec, this made headlines when they started prescribing energy cubes. It's basically 15-minute bouts of physical activity. So you go to the doc, and the doc says, you need to do 2 cubes a week. And, come back to me. And then there's some credit system that goes along with that. In New Brunswick, the New Brunswick Medical Society has endorsed doctors writing exercise prescriptions. This was 2014, so this is relatively new. But now it's the medical societies going, okay, people, we need to do this. So the tide is shifting here, and things are moving. In Nova Scotia, where I'm working with the provincial government right now to basically implement a province-wide initiative to train physicians. We're planning 5 workshops. We're going to train 150 doctors, and then we're going to evaluate the effectiveness of this outcome. And that's where I came from with the Lawson Foundation. So coming back from that meeting in 2014, I called the Lawson Foundation. They say, great, so let's do it. So that's what I did. I went on the road again. I've now been doing workshops. We did 12 workshops across the country. We've also done a bunch of, clinical rounds or whatever we can, get a talk at a medical school. We've now talked to over 1,000 healthcare providers in the last year. We've had about 250 attend a full 1-day workshop or 4-hour workshop. The other ones are more like 1-hour sessions and things when we can fit them in. But the actual workshops are designed to increase the awareness and capacity for physical activity and exercise prescription. It's typically delivered by an exercise physiologist and a physician. And that's a key thing, is that the physician's talking to physicians saying, we need to get on board and do this. It's a very big deal. Through our research, we've shown that it increases knowledge, it increases confidence by magically about 20% if they attend the workshop. It increases their prescription rate by about 20%. It shifts. And 98% of the physicians that have attended our workshop has declared that it's been high value to their practice. So that's good. Most of the physicians that we get go, wow, that was amazing. And it's because of the evidence that we provide. Now, I will acknowledge that right now we're getting the keeners, the early adopters, the people that are already kind of engaged. What we need to do next is get the next 2 levels after that, which are not past the keeners. It's kind of the next stage of adopters, and then the challenge is going to be those ones that are the contemplators and the pre-contemplators that don't want to be bothered by that. So that'll be the bigger challenge. So within our workshops, these are our objectives. To talk about the health benefits and safety, to use the exercise vital sign, meaning ask about physical activity at every appointment. We talk about physical activity counseling and exercise prescription from a motivational framework. So we talk about motivational interviewing, using rulering techniques and confidence assessment, etc. And then we actually talk about monitoring aerobic intensity, just like what's heart rate, what's RPE, how do you do that resistance band exercise. We actually do it, and we walk around at moderate intensity and go, what does your heart rate feel like? How many steps did you take? That kind of thing. Just to give them the confidence that they can talk about it with a patient and be able to answer questions about it. So this is kind of the overview of what the primary message that we send to them. That most people are okay to start low to moderate intensity activity. They don't need any fancy stress tests or anything like that. That you begin with kind of an aerobic recommendation, progress the strength over time. Walking at a moderate pace, so conversational. Most people are okay to do that. You can incorporate balance exercises and flexibility, patient-specific for older populations or whatever. Write it down. So empower the message with prescription. If they walk out of their appointment with you with a prescription for metformin, but you talked about something else, I can't remember what it was, that kind of empowers one message and not another. You're saying, why not write both? You can give them their prescription for metformin or their statin, but also give them a prescription to be more active. It'll make the medications work better anyway. And it does. Their evidence does show that the more active people are, the better the medication. And then follow-up is the key. So having some link to the community, exercise professionals, knowing who to refer to and support the long-term behavior change. So there's our guidelines. They get incorporated into our prescription pad. And as you can see, it's not a blank prescription pad. And that's because most physicians would feel uncomfortable with that because they wouldn't know what to put on it. So we kind of guide them through, maybe reducing sedentary behavior up here, or writing, frequency, intensity, time, and type, and strength activity. There's the Canadian Physical Activity Guidelines. You can provide a referral. There's some information on the back of the pad on how to start that physical activity routine. Then we've also put it in the context of a busy practice. And so using the 5 A's is a way to frame a message. So assessing and advising, so only 25% assess, 45% advise, and very few get to the agree, assist, and arrange. So we're trying to promote that. And we're trying to identify the biggest barrier that we have in primary care is time. 80% of physicians spend 80% of our appointments are less than 10 minutes. So what can you do in 30 seconds? Well, you can ask about physical activity in 30 seconds. What can you do in 2 to 4 minutes? Well, if it's low, you can prescribe a written prescription and refer to a community resource. If you do want to do comprehensive counseling, you can do that as part of your lifestyle appointment, and there's some other options there that you can do, about behavior management, etc. Most of them will do, are willing to do number 1. Many of them are willing to do number 2. Fewer of them will do number 3, although some of them do. There's a number of physicians in Wolfville, Nova Scotia that now book their lifestyle appointments at the Acadia Arena, and they go for walks around the track while they're talking about physical activity and lifestyle, which is great. But many of them will refer on for that kind of comprehensive stuff. Now the other thing that we talk about in our workshops is who you are. Who are exercise professionals? And how can we as a profession assist you in this regard. So we talk about, in addition to those that already can receive referrals for exercise, such as physiotherapists, occupational therapists, sport chiropractors, sports med physicians, there are people out there that have the training, the scope of practice, and the liability insurance to work with individuals with chronic disease. And those are the three key things. There's many personal training certifications and stuff out there, but they don't have those three things. Because no physician will refer on if they're unsure of whether or not the person that they have working with them has the liability and the scope of practice to cover that. So these are the certifications in Canada that do. Obviously the CSEP ones, the ACSM ones. As a registered kinesiologist in Ontario, obviously the scope of practice and liability insurance is covered there. And that's where we're trying to identify this EIMC professional network. So anybody of these groups, whether it's physios, sport chiropractors, registered kin, CPTs, ACSM certified, if you want to build the referral networks in your communities, that's what we're asking you to do, is to basically get on that professional network so that more people will know who I can refer to for this kind of practice. We explain that there's 2 levels here in Canada. There's 3 in the US, but 2 in Canada. The first level there is kind of like your CSEP CPT level, so 2 years of university education, and the scope to work with somebody with a stable medical condition. So they have diabetes, but it's not complex. They're on metformin or something like that. Or they have cardiovascular disease, they're on hypertension meds, but everything's basically okay. So a CPT can work with that person. A CEP and the ACSM CEPs and registered KINs can work with complex medical situations. So they have diabetes and they have COPD and they have some heart disease. Well, that might require a little bit of help. Okay, so the CEPs can work with those individuals, and they have the scope and the liability coverage to do that. So within the Exercises Medicine Professional Network, we have supporters, which are really our physicians and healthcare providers that are going to talk about exercises medicine and are going to support the message. And then we have our providers, are the ones that are going to receive referrals and do more of the work in that regard. Now we also have another major component, which is the Exercises Medicine on Campus, which is to increase awareness on university campuses, but also to integrate medical schools so we can change curriculum. Because we've identified this huge deficit in this kind of content within training of physiotherapists and medical doctors, nurses, dietitians, etc. There can be more there. And so, for example, at Dow, the med students, the physio students, and the kin students developed a clinical rounds evening where they had 10 patient scenarios, and they each went through kind of the 10 scenarios and said, what would you do in this situation? Talking about physical activity. And some of them were more musculoskeletal oriented that the physios could help with, and some of them were more kind of clinical management, and some of them were more physical activity promotion. And so they do that as part of a module. Now I know at U of T they've done a really good job at trying to include some of that stuff within the curriculum. At Queen's, they're doing whole units on it now. And McGill, they're doing whole units on lifestyle-related chronic disease prevention and management. The other thing I talk about in the workshops is what programs are available in your community. So these are the 2 medical fitness facilities I talked about. This is the Refit Center, and this is the Wellness Institute. They have multidisciplinary teams of physicians, OTs, physios, dietitians, social workers, psychologists. They have a myriad of programs all the way from cardiac rehab to COPD programs to dialysis programs to older aging, arthritis programs. They have everything. And it's amazing. I walked in there and went, this is cool. Because everybody is there. Now, what programs work well in communities? Well, the key thing with this, if you're taking somebody who's never done physical activity before and getting them to adopt it as a lifestyle, you do need a critical dose. And the critical dose seems to be about 5 to 6 hours within a 12-month period. So, although that physician prescription is very important, it's not the end. That there needs to be follow-up and involvement, either that person engaging in that behavior on their own or them getting help. And that's why those community programs are so important. And in that regard, having somewhere with modest facility and equipment, having an exercise leader, it could be an exercise professional, it could be a healthcare professional who gets training on how to lead them. The other key thing though is that you need a referral system. If these programs in the communities are going to work, you need healthcare providers to recommend people to go to them. And that's where the physician prescription and other nurses, dietitians, etc. become important in that regard. Now the other thing that we've seen is the dynamic with people with chronic disease is that they do much better in the long term when they do physical activity with other people that have that condition. If you start 10 people or 20 people with diabetes in a program together, they'll stick together. 10 weeks, 20 weeks, they're all meeting each other at the church basement, doing their resistance band and going for coffee after. You start one or two of them or tell them to go do it on their own, you may or may not see them again. But that group cohesion, and it can be disease specific in that regard. And so that is really, really important that we found. Here's an example of the primary care network in Alberta, in Leduc. And actually this one's in Calgary, the Mosaic program. So again, it's provided free of charge. Because remember that people that have those challenges, lower socioeconomic status, etc., they don't have a lot of money. So we need, healthcare dollars to support these programs. They're shown to be cost effective. Come out and get active with us. And here's the Genesis Center in Calgary, which is, they're basically trying to get that medical fitness facility kind of accreditation. And so there's programs there that can be offered. Just last couple things here. What's coming in this regard is integration of this stuff within the medical record. Okay, so the first thing is, your physical activity level as part of the medical record, just like you'd ask somebody's heart rate, breathing rate, temperature, those vital signs, physical activity is going to be one of them. And we already have this happening across the country. That would then integrate, so we have our electronic medical record, then you have the patient medical record, which is the thing that a physician or something could allow the patient to see for their lab results and stuff. This is now starting to happen. And then the third layer down is the patient support platform. And that's what's now, I'm working with a couple companies now to develop patient support platforms, which are having health coaches that help to manage a group of patients, like 100 or 150 patients, through a platform that might have an individualized prescription, it might have some diet modifications, goal-setting behaviors, tracking behaviors. If you have a Fitbit, you can download that stuff to the website and you can see what's going on. If they have any questions, you can kind of interact through the platform. You can relate them to other people with that condition so they can get kind of like blogging support and that kind of thing. And that's where we're going within healthcare. As soon as we work out all the things about privacy and all the rest of it, that's where we're going. So there's, Conduct Health, and here's the protocol view, and here's some other things. And look, hey, you can get some information about your diabetes, and if you have some questions, you can ask an expert. And I've recorded a bunch of these videos. What time of day is the best time to exercise? What exercise is best? All these other. Am I going to die of a heart attack if I go for a brisk walk? So, in summary for today, the thing I'm talking about is that exercise is good medicine, that for most patients, exercise is an over-the-counter medication, but having said that, many patients need our help because 4 to 5 Canadians are probably not active enough to achieve health benefits. So, they need more help in this regard. An individualized exercise prescription from a physician can help motivate, but active living needs to be supported by exercise professionals, systems and facilities, and healthcare dollars to make that whole thing work. And that novel opportunities exist to integrate people into this system, and that's what I hope your generation is going to take the ball and run with this. I encourage you to join the Exercises Medicine Professional Network because one of the issues that we have here is that EIMC doesn't get funding right now. Like, I mean, we support it through CSEP, through memberships, etc. And so by paying your $50 a year to join this network, it gives advocacy to the program so that we can go talk and do these workshops and talk to provincial governments and to Medivie Blue Cross, to say you should cover this service. And without those budgets, we don't have that lobby support. So I encourage you to get involved in the professional network. And of course, I'd like to thank the Lawson Foundation. They've been absolutely amazing. They've been providing the big support for Exercise as Medicine over the last year and a half. And as well, Urban Polling and Steps Count, and these are small companies, but invested very, morally and ethically in our message, and so they do everything that they can to support our workshops. So I'd like to acknowledge them and leave you with that message that exercise not only adds years to your life, but life to your years, and that it should be part of healthcare. So thank you very much.